In this video, I'm going to review the clinical features of different chromosomal abnormality disorders. So the first disorder is Down syndrome, which is from trisomy 21, which means that there are 3 copies of chromosome 21. And Down syndrome is the most common genetic cause of mental retardation. So there are 2 genetic disorders that are commonly associated with mental retardation. The first one is Down syndrome, and can you tell me what is the next one? So the next one that you should know for your step 1 is Fragile X syndrome. So Down syndrome and Fragile X syndrome are the common causes of mental retardation, with Down syndrome being the most common cause. Now, other features of Down syndrome include flat facial features, upslanting, palpebral fissures, epicanthal folds, as well as a single transverse simian crease in their hands. Now, these patients with Down syndrome are also at increased risk of acute lymphoblastic leukemia, early onset Alzheimer's disease, as well as cardiac septal defects like, for instance, atrial septal defect. Now, just to review the features of Down syndrome with you one more time. So these patients can have flat faces, upslanting palpebral fissures, epicanthal folds, as well as a single transverse simian crease. So you know how normal individuals have 2 different creases right here in their hands. Patients with Down syndrome have a single transverse simian crease. And then other features we discussed is mental retardation, as well as increased risk of acute lymphoblastic leukemia, increased risk of Alzheimer's disease, as well as increased risk of cardiac septal defects. The next disorder is Edwards syndrome, which is from trisomy 18. And the way I remember features of Edwards syndrome is that I always remind myself that King Edward is punched with a fist in the jaw. So King Edward is punched with a fist in the jaw. So features of Edwards syndrome, which is trisomy 18, include micrognathia, which means small jaw, as well as clenched hands, where there is overlap of the index finger with the 3rd finger, as well as the 5th finger with the 4th finger. And so the way this memory aid fits here is that King Edward stands for Edwards syndrome, is punched with a fist in the jaw. So fist stands for clenched hands, and then jaw refers to small jaw that is seen in patients with Edwards syndrome. And then other features that you also see with this disorder is rocker bottom feet, so rocker bottom feet, as well as low set ears. Alright, so next I would like to review the clinical features of Edwards syndrome here with the images that are provided. So basically, patients with Edwards syndrome have low set ears, and then the memory aid that we had was that King Edward is punched in the jaw with a fist. So clenched fist, where there is overlap of the index finger with the 3rd finger, and then overlap of the 5th finger with the 4th finger, is the feature of the Edwards syndrome. In addition, these patients have micrognathia, which means it's a small jaw, and then they also have rocker bottom feet, as well as low set ears. Now, for your step 1 exam, it's really important to know the lab value changes that you see in patients with Down syndrome as well as Edwards syndrome. So the test that is shown here, where it measures the alpha-fetoprotein, estriol, beta human chorionic gonadotropin, and inhibin levels in the maternal serum, is called quad or quadruple test. And this test is basically done at 16 to 18 weeks of gestation. And the lab changes that you see with Edwards syndrome is there is a decreased level of alpha-fetoprotein, estriol, and beta-HCG, but normal levels of inhibin. And then in patients with Down syndrome, there is decreased level of alpha-fetoprotein, estriol, but elevated level of beta-HCG and inhibin. So the memory aid that I used for myself is called HIGH. So what this memory aid tells you is that HCG and inhibin are the two values that remain high in patients with Down syndrome. So beta HCG for H and then inhibin for I are the values that remain high in patients with Down syndrome, while alpha fetoprotein and estriol levels drop in the blood serum of mothers who have children with Down syndrome. Alright, so one other point I would like to discuss is the guidelines for the screening test that needs to be done during pregnancy. So I already told you that at 16 to 18 weeks of gestation, quad test will be performed on the maternal blood. At 26 to 28 weeks of gestation, mother's blood sugar will be tested for any possible gestational diabetes. And then 36 to 38 weeks of gestation, you screen mothers for group B streptococcus. So you don't need to know these guidelines for your step 1 exam, but you will encounter them during your OBGYN rotations as well as for step 2 and step 3 exam. So I thought since I already discussed the quad test, I should probably review the other 2 screening tests with you as well. And it's actually not hard to memorize these guidelines, knowing that the numbers 6 and 8 is in all these screening tests. So 16 to 18 for quad test, 26 to 28 mother's blood sugar test, and then 36 to 38 weeks of gestation screening for vaginal group B streptococcus in pregnant patients. In any case, back to the table here. So here I would like to test your knowledge one more time. Can you tell me how the values for alpha fetoprotein, estriol, beta HCG, and inhibin are affected in patients with Down syndrome? So basically the ones that remain high are HCG and inhibin remain high. So these two are high, while alpha fetoprotein and estriol are low. And then with the Edwards syndrome, all values were low with the exception of inhibin that was normal. Alright, now back to the table. The next chromosomal abnormality disorder is Patau syndrome, which is from trisomy 13. And one important point that you should know here is that Down syndrome, Edwards syndrome, and Patau syndrome are the chromosomal abnormality disorder that are commonly associated with increased maternal age. So as females get older, their children are at increased risk of developing any one of these 3 chromosomal abnormality disorders. In any case, patients with Patau syndrome have defect in the development of the precaudal mesoderm, and so therefore these patients can develop microophthalmia, which means that they have small eyes. They can also have holoprosencephaly as well as cleft lips and palates. And then in addition, these patients can have polydactyly, which means that they have extra sets of fingers. And so the way I memorize this feature is that patients with Patau syndrome, which is trisomy 13, have 13 digits. So instead of having 10 fingers, these patients have 13 fingers. And this way I can memorize polydactyly as a feature of Patau syndrome. The next 2 disorders are Turner syndrome and Klinefelter syndrome. So Turner syndrome is an X chromosomal abnormality disorder. So one of the X chromosome is missing in these females, and so therefore they have 45 chromosomes. While Klinefelter is 47 chromosome disorder where there is an XXY chromosome. So there is an extra set of chromosomes in patients with Klinefelter as well. And so for the memorization of the features of these disorders, here I have provided you with an image. So patients with Turner syndrome have short stature as well as ovarian dysgenesis. As a consequence of which, since there is ovarian dysgenesis, there is low level of estrogen in these patients. So these patients will have primary amenorrhea in addition to the lack of breast development. Other features that you see in these patients is horseshoe kidneys, bicuspid aortic valve, as well as preductal coarctation of the aorta. And then finally, due to the problem with the lymphatics in these patients, there is enlargement of the lymphatic sacs, which will result in the formation of cystic hygroma. But then later on, these lymphatic collections will resolve, as a consequence of which a loose skin will remain around the neck. So basically, these patients have webbed neck, which means that there is an extra fold of skin over their neck areas. And then the next disorder that we had was Klinefelter or XXY. So these patients have tall stature, but then due to the damage to the seminiferous tubules as well as Leydig cells, there is decreased level of testosterone but elevated level of estrogen. And so from decreased production of testosterone, these patients will have hypogonadism as well as testicular atrophy. Gynecomastia as well as infertility. And then these patients have female pattern of pubic hairs. Now, a high yield point that you will need to know about these two disorders is how the levels of estrogen, follicular stimulating hormone, as well as luteinizing hormones are affected in patients with Klinefelter disease as well as Turner syndrome. So basically, in patients with Turner syndrome, since there is dysgenesis of the ovaries, therefore there would be decreased production of estrogen, as a consequence of which there would be positive feedback to increase the level of FSH and LH. So basically that is simple. With Klinefelter, on the other hand, there are two damages that are made. One is Leydig cells that are not functioning properly, as a consequence of which there is decreased level of testosterone. And then there is also damage to the seminiferous tubules, as a consequence of which now there is decreased secretion of inhibin. And basically, inhibin is a hormone that is secreted by Sertoli cells, which are located in the seminiferous tubules. So once there is damage to the seminiferous tubules, therefore there would be decreased secretion of inhibin. And naturally, inhibin inhibits the secretion of FSH hormone. So decreased secretion of inhibin will result to increased secretion of FSH, while decreased secretion of testosterone via positive feedback will result in increased secretion of LH. And there is also increased positive feedback to increase secretion of the aromatase enzyme. And can you tell me what is the function of the aromatase enzyme? So the aromatase enzyme converts the male hormone into estrogen. So now that there is an increased LH production, luteinizing hormone will keep on stimulating the Leydig cells to produce more testosterone. But at the same time, there is also elevated level of aromatase, as a consequence of which any extra testosterone that is made will be converted into estrogen. So these patients will have elevated FSH and elevated LH. Elevated LH along with elevated aromatase will stimulate the Leydig cells and increase the production of estrogen. So these are important lab values that you will need to know for patients with Klinefelter syndrome as well as Turner syndrome. And so once you pay attention to the clinical features, it all makes sense. Patients with Klinefelter have elevated level of estrogen, as a consequence of which these patients develop gynecomastia as well as female pattern of pubic hairs. While patients with Turner syndrome have low level of estrogen, as a consequence of which there would be primary amenorrhea, which means that these patients will not undergo menstruation, in addition to the lack of the secondary sexual characteristics. So patients with Turner syndrome will not develop any breast, and there would be lack of pubic or axillary hair. So the secondary sexual characteristics will be absent in these patients. In any case, moving on to the next disorder. And then the final disorder that we have here is XYY syndrome, where these patients have very tall stature as well as severe acne. And then these patients are also at increased risk of developing attention deficit hyperactivity disorder as well as aggressive behaviors. Now, to quickly summarize all the findings that I just discussed with you, patients with Down syndrome, Edwards syndrome, and Patau syndrome, these three are commonly associated with increased maternal age. Down syndrome is trisomy 21, which is the most common cause of mental retardation. So what was the other genetic disorder that was associated with mental retardation? And the answer is Fragile X. So Down syndrome is the most common cause of mental retardation. These patients present with upslanting palpebral fissures. So let me show you in the image. So patients with Down syndrome present with upslanting palpebral fissures, epicanthal folds, as well as flat faces and a transverse semian crease. And then one other feature that was not shown in the image is low set ears. And then patients with Down syndrome are at increased risk of developing acute lymphoblastic leukemia, Alzheimer's disease, as well as cardiac septal defects. Next disorder is Edwards syndrome, which is trisomy 18. And the memory aid that we had was that King Edward is punched in the jaw with a fist. So these patients have small jaws or micrognathia, as well as clenched hands, where the index finger is overlapping the third finger, while the fifth finger is overlapping the fourth finger. And then low set point ears, as well as rocker bottom feet, are other features that you see in patients with Edwards syndrome. So here, just to review these findings one more time. So low set ears and small jaw, rocker bottom feet, as well as clenched fists are features of patients with the Edwards syndrome. The next disorder is Patau syndrome, or trisomy 13, where due to defects in the precordial mesoderm, there is problem with the formation of the midface, eye, and forebrain. So problem with the formation of the eye will result in microophthalmia. Problem with the formation of forebrain will result in holoprosencephaly, where the double lobes of the brain fail to separate. And then finally, problem with the midface is associated with cleft lip and palate. And then one other feature that you should know is that patients with trisomy 13 are presenting with polydactyly, which means that there are extra sets of hand digits. So once again, the memory aid for Patau was that patients with trisomy 13 have 13 fingers. So polydactyly for Patau syndrome or trisomy 13. And then rocker bottom feet is one other feature that in addition to Edwards syndrome, you can also see in patients with Patau syndrome. Turner syndrome, or XO, is associated with the short stature and primary amenorrhea and lack of breast development due to the dysgenesis of the ovaries. So since there is dysgenesis of ovaries, there is not enough estrogen production, as a consequence of which there is primary amenorrhea as well as lack of breast development. And then since there is problem with the lymphatics, these patients will develop cystic hygroma, which after it resolves, there is an extra fold of skin that will cause development of webbed neck. Other features of patients with Turner syndrome is bicuspid aortic valve, preductal coarctation of aorta, as well as horseshoe kidneys. So once again, memorization of these features is much easier if you recall this image. So short stature, ovarian dysgenesis, lack of breast development as well as primary amenorrhea, horseshoe kidneys, preductal coarctation of the aorta as well as bicuspid aortic valves, and finally webbed necks are features of patients with Turner syndrome. While patients with the Klinefelter or XXY syndrome are presenting with tall statures and long extremities. Due to the problem with the Leydig cells, there is decreased production of testosterone, but increased secretion of estrogen. As a consequence of which, these patients have female pattern of pubic hairs, testicular atrophy, gynecomastia, as well as infertility. So now here I have a question for you. With the Turner syndrome versus Klinefelter syndrome, how do the levels of estrogen, FSH, and LH will be affected? Could you fill this table for me? And so basically, we discussed that in patients with Turner syndrome, due to ovarian dysgenesis, there is low level of estrogen, which will cause positive feedback to increase production of follicular stimulating hormone and luteinizing hormone. With Klinefelter, on the other hand, due to problem with the Leydig cells, we have decreased level of testosterone, which will provide positive feedback to increased level of luteinizing hormone, and then there is also elevated level of aromatase. And so luteinizing hormone will continue acting on the Leydig cells for stimulation to provide more testosterone, but any testosterone that is produced is being converted by aromatase into estrogen. So therefore there would be elevated level of estrogen in patients with Klinefelter disease. And then also due to the defects in the seminiferous tubules, there is decreased production of inhibin, which will result in elevated level of follicular stimulating hormone in these patients. Now back to the table. So we already discussed the Turner syndrome. Patients with Klinefelter due to damage to seminiferous tubules as well as Leydig cells are presenting with hypogonadism, testicular atrophy, gynecomastia, and infertility. And these patients also have tall stature and long extremities. And then the final disorder we are discussing here is the XYY syndrome, which, as the name implies, has XYY chromosomes. And these patients have very tall statures with severe acne, and there is also increased risk of development of the attention deficit hyperactivity disorders as well as aggressive behaviors in these patients. And that concludes our discussion of the chromosomal abnormality disorders.